Thank you, sir, and good evening to everyone. So I'll just start my talk. So my topic is the root cause analysis and microbiological surveillance in an event of cluster endophthalmitis. So we've heard all the eminent speakers before elaborating on how to prevent it and how to manage it and how to have the documentation and everything. But when an actual event happens, when anybody is faced with an outbreak, everybody is so anxious to know what actually caused it and then to stop it as quickly as possible so that we can prevent further cases from happening. So that's what I'm going to be talking about. So the first most important aspect to be considered is the time. So if an outbreak is suspected, an outbreak need not be like 5 cases, 10 cases. It should be anything which is more than what is routinely seen. So that should be the definition everybody remembers. Even if you're going to get one case more than what you normally see, 1 or 2 cases within a certain time period, you should have a suspicion that it could be a cluster, and immediate action must be taken so that we can implement a root cause as early as possible. Because we know the faster we do, if we delay it more, people will tend to forget the details, and they would forget the protocols which they followed, and then we might also lose a lot of important consumables that need to be tested. So all this, considering the time is of essence here, and also time should be given to the investigation team to gather all the information that is needed. And all this is very important to prevent any further cases from coming or even preventing future outbreaks. And one point which I would really like to emphasize here is, whoever is going as an investigating team or whoever is doing a root cause analysis in your own hospital, or you've been asked to come to some other hospital, it is be very important if they have some basic knowledge of ophthalmologist. Of course, everybody knows, but anybody else in the team, especially the microbiologist, if they have a knowledge of what is the protocol that's commonly followed, that will be very easy to start doing a root cause analysis. And there is this publication in IJO by Desai et al., which is very nicely, she has put some recommendations for investigating cluster endophthalmitis. So if anybody who really wants to have more in-depth knowledge can read this paper. So as I said, if a team is constituted, each one should be very aware of what is their role and start doing according to what is given to them. Now coming to the role of the microbiologist per se, as I mentioned, if the microbiologist is already actively involved in the theatre activities, the ophthalmic theatre activities, the CSSD activities, and they already go for a routine audit, or they have a HIC, the part of the HIC team, then they might be already having a checklist, to start going and doing an audit. And first thing what they should be doing, or we should be doing, is start a step-by-step analysis of all the incident which actually happened. How many cases, who operated, the date, and all those things. And then go through all the various protocols. And then finally start the sample collection. So this is before I go into my actual root cause analysis talk, I just wanted to share this experience which we had, which both Dr. Ardia sir and Saravanan actually mentioned this case scenario which happened to us. So this was very interesting. As sir mentioned, a few cases started coming which was operated elsewhere with just a wound infiltrate. Some cases had some vitritis, and actually no case had a very frank bad endophthalmitis. And those cases grew this gram-negative bacteria both from the wound infiltrate and from the vitreous. And then as sir actually showed this slide, as you can see, an interesting thing is the day of presentation. So the first case only presented only after 12 days. So long time period that shows itself this organism is very slow growing organism, and it wasn't very virulent also. So after 5 or 6 cases, then we were invited to that hospital, and then we started doing a thorough investigation, and we took the samples from all the relevant areas, and whatever is possible we started collecting the samples. And normally when we go, especially after such a long 10 days, nearly for 2 weeks have been passed, very difficult to find the source of infection. But in this scenario, when we did a microbiological investigation, so as is routine for us, we just went about systematically collecting samples from wherever areas even though they may not be directly related to the actual endophthalmitis, we just started collecting from everything because we didn't know, what to collect or what to leave out and what we would be missing. So as you see, there were some growths which were actually not related to the actual endophthalmitis patients. So we also started seeing from the patient's eye drops and from the eye drops which were there in the OT also. And then we saw this one eye drop which topical anesthesia which grew this organism Burkholderia. So then we went and purchased and got some more of this same batch of this company, and that also grew this organism. Unused sterile pack also grew the same organism. And then we speciated it and we did a box PCR to see for the clonal relationship to really prove that this is the same organism which grew from the patient's eye and also which was isolated from the sterile bottle. So this is the kind of scenario which most of the people, the doctors might be facing, and this is where I think Mr. Krishna Kumar's talk will be adding some light into such a kind of scenario. So now coming to the actual starting the root cause analysis. So going by the published literature, we can see that each and every item that goes into the eye has at one point of the time been a culprit in causing cluster endophthalmitis. So because of the either the break in sterility or because of the storage conditions or for some reason it's already a pre-sterilized consumable could become contaminated, or some break in the protocol could lead to this thing. And then also, even if it's not the actual consumables, even other things like improperly maintained autoclave instruments, sometimes the autoclave is not serviced properly, poor operating room hygiene, contamination of ventilation system, although these might not be directly related. We see very, very few reports of actual ventilation system causing cluster endophthalmitis. So the organism profile, if you see, so this is very important for us to have a clue. So if the vitreous sample is going to start growing such kind of profile, then immediately it should external contamination should be suspected, because none of these organisms are actually a normal flora. They're all part of growing in the environment, water contamination, soil flora. Especially Pseudomonas sootzuri, nowadays we are seeing a lot of Pseudomonas sootzuri infection. So this is not as virulent as Pseudomonas aeruginosa. So it's much more slow growing, and actually the outcome is much better than aeruginosa. So recently also in a nearby a place we saw 2 outbreaks of this. So when we're going to start a microbiological surveillance in a scenario of an outbreak, I'm not talking about a routine surveillance, it's very important that we have a plan on where to take the swab. So either we collect too many samples or too many swabs are collected will give a confusing picture, and then finally the interpretation might become very difficult, because obviously if you're going to collect too many swabs, something is going to grow. Definitely the place is not going to be very sterile. So whether that is going to be implicated or not, all these are very sensitive issues and emotional issues also. So much of it's the law is involved, the media is involved, patients are involved. So this interpretation of culture results should be with the correlation, and clinical knowledge is very important for us to give the report. So the role and the responsibility of the investigative team in analyzing. So we can, as I mentioned, we can start going by the checklist, and a checklist can have all these questions that need to be answered. So if you go systematically, this might give you a clue as where the problem could have started coming. Like in that instance, when I was mentioning that outbreak of Burkholderia and where the anesthetic eye drop was involved, the surgeon had a practice of putting the eye drop on top of the blade just before entering. So that is why that port of entry had a lot of infection there. Again, this data, this table is got from this paper. So people can go back and refer this paper if you want to create a checklist. And then also the culturing of potential source of infection. As I was mentioning, we also actually whenever we are called to do anything, we go about testing all this. But again, caution should be taken whether you really want to go and culture all these areas. But definitely what should be cultured is the consumables if it is available. And then finally, after doing all the culturing, getting the microbiology report, it is better to first start giving a preliminary report. So first initial report can be given to the hospital or given to the concerned authorities, whoever is involved in that, about what is our plan, what materials we've gathered, and what is our plan for analysis. Then after the microbiology report is finished and completed and all the analysis is done, a final report should be given, and it should be properly written, because the report is what is going to be really important, in handing over to whoever is responsible, all the health authorities or the lawyers or anybody. And if the possible source is identified with a strong evidence, that can definitely be mentioned. And suppose if there is any recommendation for improvement in the theatre, that should also be mentioned. And if any remedial measures to be taken also should be mentioned. So I just want to conclude this talk by putting a slide on, we've spoken about root cause analysis, but root cause analysis becomes very, very much more easier if preventive measures are already in place. So how Dr. Sivakumar mentioned in detail and Dr. Raiviti mentioned the preoperative prophylaxis, if all that is already there, so first, most important is the responsibility of the doctors. Many places maybe the surgeon just comes and operates and leaves, and they might not be actually involved in the day-to-day activities. So I was just thinking like how we do a code red mock drill or a mock drill for a code blue. Even if a code like a mock drill is done for a cluster, and if you're already ready, prepared, like how we are going to face in case you're going to meet with a cluster, then that makes it so easy if and ever if anybody is faced with an outbreak of infection. So if the doctors get themselves oriented to what the protocols, and if they take part in the OT CSST meetings, if they also check all the registers, make sure all the manpower is adequate, training is adequate, and all the instruments are serviced properly, and if there's any issues happened, what action was taken, and a periodic audit is very, very important in the operation theatre. And so finally we know that it's very difficult to identify the cause in most of the situation. Proper plan for collecting the sample, a lot of responsibilities for the investigative team, especially when reporting contamination in sterile products. So the lab must make sure that they have all the measures in place to do an analysis for testing of a sterile product. And so finally, to conclude, we all know that we want for the best for the safety of the patients is our priority. But in spite of all protocols being followed, outbreaks tend to happen because of multiple factors. And most important is we should try not to compromise on the quality of the consumables and which is going to be used. And proper documentation, as has been mentioned by each and every speaker till now, is going to be the most important take-home message from this seminar. And a lot of references are available right now, right from AAO's task force reference, Royal College, the NPCB guidelines is also available, and the ECRS. So it is very good if we can go through all this and equip ourselves with more knowledge. Thank you.